Hello, Dr. Najim here with another video. So this video will be about diarrhea. What is diarrhea? How are you going to define according to WHO? And what are the different types of diarrhea on the basis of severity, on the basis of duration? What is the possible workup? What the possible causes? And what are the treatment options that are available for diarrhea and how you can prevent? So, according to WHO, diarrhea is defined as if the child is having 3 or more watery stools in 24 hours, uh, or if the child is passing more frequent stools than the routine, then it can also be labeled as diarrhea. Or if there is a single episode of loose stool that is voluminous stool than the routine, then it can also be labeled as diarrhea. So the diarrhea can be acute, can be chronic, can be persistent. So it depends upon how long the diarrhea lasts. So if the diarrhea is lasting for less than 14 days, it will be labeled as acute diarrhea. If it is lasting for more than 14 days, it can be persistent or chronic diarrhea. Persistent diarrhea is usually used for infectious causes, and the chronic diarrhea is usually used for non-infectious causes. And a child is labeled as having chronic diarrhea if the duration of diarrhea is more than 4 weeks. So when you talk of the acute diarrhea, so acute diarrhea is acute onset of the loose stools and less than 14 days have passed. So among that, the most common cause is the virus, and among the viruses the most common cause is rotavirus. So rotavirus is the most common cause of a child as having acute watery diarrhea that is non-bloody, that is not having any mucus, though they can be fever that can be up to 1 or 2 degree Fahrenheit for the first 2 to 3 days, because of the infection, as it's an infectious etiology, and secondly because of the dehydration. Other causes in the viral diarrhea include the norovirus and the adenovirus. These are the common causes. In the countries where the children are routinely vaccinated for the rotavirus, so then in that countries norovirus is defined as the most common cause of acute diarrhea. Then comes the persistent diarrhea. So if the diarrhea is lasting for more than 2 weeks, and is thought to be infectious diarrhea, then is labeled as persistent diarrhea. If the diarrhea is lasting for more than 4 weeks and is not non-infectious in origin, so it is labeled as chronic diarrhea. So the etiology and the causes and the presentations and the systemic features for each of the diarrhea is different, that we are going to discuss later. So this picture is showing you the common causes of acute and chronic diarrhea. Among the common causes of acute diarrhea, so first I have told you that the viral diarrhea is the most common type of acute diarrhea. And in the viral diarrhea we have norovirus, rotavirus, adenovirus, rotavirus being the most common cause. Other causes include food poisoning, especially if raw or uncooked or not properly cooked products are being consumed by the children. So such as those caused by Staph aureus. So it is usually associated with food poisoning, and in such cases there will be acute onset within few hours of the ingestion of the contaminated products. The child starts having pain, abdomen and vomiting and diarrhea associated with the severe dehydration that usually lasts for 24 to 48 hours, and all you need is the taking care of the hydration and preventing the dehydration. Then comes the infections. I've already told you about the viral causes. Certain bacteria also cause acute watery diarrhea, in which you have salmonella, vibrio cholera, and E. coli, especially in cases of traveler's diarrhea, and especially if the child is having high fevers with pain abdomen and diarrhea that is containing blood and mucus, so it is most likely to be bacterial diarrhea. In such cases, Shigella, enterohemorrhagic E. coli, and Campylobacter jejuni. These are the common causes that usually cause the acute bacterial diarrhea, and for that cases antibiotics may be required along with the taking care of the dehydration. Then comes the traveler's diarrhea, especially if there is a history of traveling to certain areas and consumption of by the road available products. So these can cause the traveler's diarrhea, that is short limiting and may require antibiotic therapy as well in severe cases. Then comes the chronic diarrhea. So in chronic diarrhea you have conditions like prolonged bacterial diarrhea, post-enteritis syndrome, in which there is basically transient deficiency of disaccharidases. So the disaccharides in the carbohydrates are not being properly digested, which can cause osmotic diarrhea, like transient lactose intolerance that is seen in the infants following diarrhea. Then comes the food protein allergies, or food protein allergy, cow milk protein allergy, soya protein allergy, or food protein induced enteritis syndrome, that basically the proteins induce, so in which the proteins usually induce an inflammatory reaction, causing blood and mucus to come in the stools. Initially there is only acute watery diarrhea, and then it converts to the chronic diarrhea and may associated with the weight loss or failure to thrive, failure to gain weight, and some other allergic symptoms may be evident over the skin. But as this is a non-IgE mediated disorder, so the disorders are usually related to the gut. However, there may be vomiting, there may be features of gastroesophageal reflux associated with this protein allergy or intolerance. Then comes the irritable bowel syndrome. Certain medications like antibiotics may cause diarrhea, overuse of laxatives may cause diarrhea. Then comes the celiac disease, or the wheat protein allergy, or the gluten enteropathy. So this is the disease was also associated with the chronic diarrhea. So based on the age, if the age is about early infancy, so in that cases, among the acute you have the viral causes, bacterial causes, certain parasitic causes. We also cause acute watery diarrhea initially, and later on it's associated with the weight loss. Among the non-infectious etiologies of the chronic diarrhea, firstly you have the cow milk protein allergy, soya protein allergy, food protein allergy. Then comes the celiac disease. The celiac disease usually after 6 months, when the child is started on weaning, and especially on the grains like barley, wheat, barley, rye, oat. So all of these contain gluten, and in cases where the child is allergic to gluten and he is not able to digest that, so it may result in the gluten enteropathy, which initially starts with the recurrent episodes of diarrhea or constipation alternating with diarrhea, abdominal distension and dyspepsia, and faltering growth, and early development of caries in the teeth, and short stature, and iron refractory iron deficiency anemia. So all of these features are related to the celiac disease. Then certain immunological conditions like HIV, or immunodeficiencies like severe combined immunodeficiency or common variable immunodeficiency may present with the recurrent episodes of diarrhea, and may have recurrent, and there's recurrent history of RDIs and pneumonias and the failure to thrive usually in the early infancy. So these are the immunodeficiencies. Talking of that, in older children you usually have similar causes like prolonged bacterial illnesses, or prolonged bacterial diarrhea, post-enteritis syndrome, parasitic diseases, neoplastic diseases, immunological diseases, and other entities include the celiac disease and the inflammatory bowel disease, irritable bowel syndrome. Another important cause that starts to develop in the early infancy is the cystic fibrosis, pancreatic insufficiency like Schaumann-Diamond syndrome. So these conditions also presents with the chronic diarrhea, and associate with the weight loss, and associate with the micro and macronutrient deficiencies, and the faltering growth, and the short stature. So all of these conditions are usually present in patients with Schaumann-Diamond disease or cystic fibrosis. So among the medications I've already told you, the antibiotic induced diarrhea, common cause is amoxicillin and clavulanic acid, other condition like azithromycin, and then upon was pseudomembranous colitis, which also occurs as a result of antibiotic induced enteritis, in which they are usually bloody diarrhea. So in that case, there's is usually the offending agent is the antibiotic that you took previously for diarrhea, and that may be associated with the fever and the pain abdomen, and usually you test for that by doing a stool for Clostridium difficile antigen testing, and the therapy is also you use the antibiotics for the treatment of pseudomembranous colitis. So there are certain conditions which are not diarrhea but they mimic as diarrhea, such as if there is severe pain, abdomen, and fever, and is diarrhea. So and there is diarrhea. So you can think of appendicitis, which is the abdominal tenderness is there, or intussusception in younger children, in which there is initially watery diarrhea, there is crampy pain, and there are episodes of inconsolable cry, in which the child raises up the legs towards the abdomen, and later on there is a recurrent jury stools, and that is usually confirmed by ultrasonography, which confirms the intussusception to be the cause. So how you're going to take the history from a patient with diarrhea? So good history taking is very much important in assessing a case with diarrhea. First of all, you will be able to identify the cause earlier. This will help you in help you in guiding the best investigation and avoiding the unnecessary and time-taking investigations, and this will also help you in timely developing a diagnosis, and timely starting the best therapy, which will ultimately shorter the duration of illness and will improve the outcome, and will also reduce the economic burden over the patient by preventing the unnecessary and expensive investigations, and will also help in preventing the child from undergoing aggressive workup and treatment. So the first thing that you talk of or you ask from a patient with diarrhea is how long the patient is having diarrhea. So what is the duration, what is the consistency, what is the relation with the food, and how many episodes are there. If the episodes are so much watery that if for a younger child they are coming out of diapers and causing severe dehydration, association with the vomiting, any associated with the fever, pain, abdomen, cramps, any history of passing blood or mucus within the stools, or any history of oral ulcers, joint pains, and abdominal cramps, any perianal diseases, or perianal swellings or abscesses, or any skin lesions, any history of jaundice, any history of vomiting, any history of traveling, any history of recent consumption of food, any recent changes in the diet, any recent changes in the milk or in the milk formula, what is the bottle hygiene, if the infant or the child is bottle fed. So all of these cases, or any recent initiation of wheat based products in a child, so all of these things that you need to ask for. So if the child is having fever and the diarrhea is watery, green in color, though there's frequent watery stooling or defecation, and there is no blood and mucus in the stool, so most likely thing will be the viral cause. If there is high grade fever associated with the pain abdomen, if there's some blood in the stools or mucus in blood and mucus in the stool, the most likely cause will be some bacterial diarrhea. If there is history of low grade fever, no fever at all, there is abdominal cramps, and there is frequent defecation, and there is only a small amount scanty stool is passed, and its major portion is mucus, colorless and frothy, so it's most likely some parasitic infection like entamoeba histolytica, right? uh, then if there was a previous year of diarrhea and now the diarrhea improved, and then there's recurrence of watery stools that are causing some sort of perianal rash, and most likely carbohydrate malabsorption can be because of the post-infarctus syndrome or secondary disaccharidases deficiency. If there is recent introduction of some milk formula, some new milk formula, it could be because of that milk protein allergy. If there is recent initiation of any grains or wheat based products, and there is initially watery diarrhea that has ultimately converted into chronic diarrhea and it is causing weight loss, so it could be uh, celiac disease. If uh, if the child is not having fever, but there is history of chronic diarrhea and the stool are very offensive and pale and sticky, and they float over the float over the pot, and they are difficult to flush or difficult to clean. It is difficult to clean the child. The skin becomes greasy after defecation, and there is associated micro and macronutrient deficiency associated with the weight loss. There's some delayed passage of meconium at birth, and there also history of recurrent arteries, usually signifying pointing towards cystic fibrosis. If there is only complaints related to the GI with a chronic diarrhea, that is basically a pasty, greasy stools that are foul smelling and offensive and causing weight loss along the micro and macronutrient deficiencies. So it can be because of the pancreatic insufficiency, because the Sherman-Diamond disease, or some other cases like A beta lipoproteinemia. uh, if the along with the diarrhea the child is having recurrent RTIs, recurrent oral ulcers, generalized lymphadenopathy, some hepatosplenomegaly, it can be because of HIV, recurrent mucocutaneous candidiasis or skin infections or eczemas. It can be because of the protein allergies, or certain immunodeficiencies will also present in the similar way. So this is how you basically come towards diagnosis, simply from asking this much questions. In certain cases, poor bottle hygiene and is the sole cause of causing recurrent episodes of diarrhea in a child, or in certain cases the milk is not properly diluted, the milk is overly diluted, due to which there is recurrent episodes of diarrhea and faltering growth. So all of these conditions are such that they can be suspected over the history, and then can lead you towards a proper diagnosis. So in this way you will advise the best investigation and the least number of investigations, and in so many cases you can avoid the uh, investigations that are very costly. So that this is why a good history is very much important in coming towards a diagnosis. So then comes how you're going to assess a patient with diarrhea. So first of all, anything and above anything is the conscious state of the patient, whether the patient is alert, oriented in time and space, or is irritable or restless, or is lethargic, drowsy, or unconscious. So this will tell you that the degree of the dehydration is mild, moderate, or severe. Then comes the this is the general appearance. The patient is alert, oriented, or is toxic looking, or is restless or irritable, or the eyes are uh, normal and moist and teary eyes, or the eyes are dry. The child is crying, but there are absence of tears and their dry eyes, and their sunken eyes. What is the skin tugger? What is the skin fold? It goes quickly or it takes a bit time. What is the capillary refill time? If the child is able to take orally or not. So you are going to classify as no dehydration, some dehydration, or severe dehydration. If the dehydration is about 2 to 5%, so it is no mild dehydration. If the dehydration is about 6 to 9%, if it is moderate dehydration. If the more than 10%, it is taken as severe dehydration. Then comes if the child is alert and oriented. So this comes under the no dehydration. If it is restless, irritable, it is but is thirsty, it is able to take orally, it is taken as moderate dehydration. Lethargic, unconscious, drowsy, not taking orally, not interested in surroundings, is taken as severe. If any of the danger signs are present, like the child is vomiting everything, or is a high fever, or showing convulsions, then it is also coming under the severe disease. Then comes the capillary refill time. The capillary refill time is less than 3 seconds, is taken as normal or mild dehydration, and if it is more than 3 seconds, it is taken as more 3 to 5 seconds, so it will be taken as moderate to severe dehydration. If the pulse is good volume, is taken as no dehydration. If the pulse is low volume or feeble pulses, will taken as moderate to severe dehydration. If the heart rate is normal, it is taken as no dehydration or mild dehydration. If the heart is slightly increased or is much increased, it is taken as moderate to severe dehydration. So the table that is in front of you is showing that if there is no enough sign to classify as some or severe dehydration, it will be labeled as no dehydration. If there are two or more of the following signs are present, like restlessness, irritability, sunken eyes, drinks eagerly, thirsty, and the skin pinch, skin goes very slowly, so it is taken as some dehydration. In severe dehydration, two or more of the following signs are present. The child lethargic or unconscious, is having sunken eyes, unable to drink or drinks poorly, and the skin pinch goes back very slowly, more than 2 seconds, so it will be taken as severe. So other things are also important. You check for the temperature, you check for the history of the urine output, and you check if the breathing is deep or small, acidotic breathing, what is the BP, is recordable or not, what are the anthropometric measures, if it allows us any micronutrient macronutrient deficiencies, and then you take the weight and height, and then plot according to the age, if it comes under the uh, moderate to severe wasting or stunting or not. So on the basis of that, you are going to classify if the child is PCM, protein caloric malnutrition, kwashiorkor, or marasmic or not. So you are going to ultimately decide your management plan according to the severity of dehydration and the condition of the child, whether or not antibiotics are warranted or not. So this is a basic early assessment, and after that, if the child comes under the category of no dehydration, then only outpatient management is required. In case of acute diarrhea, you give oral rehydration solution, oral zinc, vitamin A may be given in some cases, probiotics are can be given, which are known to shorten the duration of diarrhea. Then symptomatic management, if there is fever, you can give oral paracetamol 6 to 8 hourly depending upon the condition. And if child is vomiting, so you can give some oral antiemetics in the form of oral ondansetron, having a fewer side effects. If it's some dehydration, then you're going to give oral ORS along with the KYB diet, in which you're going to give banana, yogurt, and rice, and potassium rich foods like banana, and then give oral ORS as much as the child can drink, plus 50 to 100 ml with each stool for the infant, and 100 to 200 for older children for each stool that the child is passing, along with the oral zinc and the probiotics. In case of severe dehydration, you have to give the IV. You have to admit the child. Inpatient management is required, and IV fluids are going to be given 100 ml per kg. If the child is infant, then 30 ml per kg to be given in the first hour, and then 70 ml per kg in the next 5 hours. And then you reassess the child and recategorize into the some severe or no dehydration, and then manage accordingly. If the child is more than 1 year, then 30 ml per kg needs to be given in the half hour, and the next 70 ml per kg needs to be given in next 2.5 hour. So and then you are going to reclassify. Along with that, you can give oral if the child is able to take orally. Then you can give ORS as much as the child is able to drink. About in case of some dehydration, give 70 ml per kg oral ORS, and in case of severe dehydration, along with the IV fluid, you can give oral ORS as much as the child can drink, plus with each loose stool 50 to 100 ml for infants, and for younger children about 100 to 200 ml with each loose stool that the child passes. Plus you are going to continue the breastfeeding, and if the child is able to take things other than milk, then you can give boiled rice, khichdi, yogurt, and banana. These are the things that are potassium rich, and they basically add bulk to the stool and reduce the watery consistency. And along with that, you're going to give zinc and oral ORS. So if the child is sick looking, having high fevers, and you are thinking that if the child is having bacterial diarrhea, then you can give antibiotics as well. uh, Nitazoxanide is a drug that can be used for viral diarrhea. It has a short course of about 3 days and is known to shorten the duration of diarrhea as well. So it can be given in patients in which you are suspecting viral diarrhea, and it also has antiparasitic and antibacterial effect as well. However, the mainstay of the treatment is oral ORS, zinc, probiotics. So these are the things that you're going to give to a patient, to a child who is presenting to you with acute diarrhea. For chronic diarrhea and persistent diarrhea, we will be making another video uh, later on. Today's video was about how to approach a child with diarrhea, what question needs to be asked, what differentials you need to have in mind, how you're going to assess whether it is no dehydration, some dehydration, severe dehydration, and how you're going to do the management. Okay, so this was all for today. We will be back with another video. Hope this video is going to add some of the clinical knowledge to your already available vast information. Thank you. Stay tuned to the channel, like and share the video, subscribe the channel, and we will be back with another video tomorrow. Thank you.